Alex, welcome to the podcast, man. I appreciate you taking the time to join and talk about pathogen genomics in healthcare. So, kicking it off, man, according to you, from your perspective, you've been beating this drum for the past decade, more or less. What is pathogen genomics and why is it important in healthcare?
Thanks for having me on, Kevin. And this is a topic I'm super passionate about and have been trying to look into for such a long time. From the perspective of healthcare, when we think of pathogen genomics, it really goes back to, in my sense, doing like detective work of transmission within healthcare. Because typically for such a long time, the standard has been culture-based methodologies or PCR-based methodologies where we can find positive tests, but when we're able to add genomics on top of that, it gives us another layer of understanding of doing DNA fingerprinting on pathogens to see how stuff is spreading in the hospital, which the more it's expanded, it opens up a huge opportunity for infection prevention. And that's coming, my background where I'm coming from. So I feel relatively new to this field. It's been around a lot longer, but I see its value, and that's what I'm excited about, is doing that type of work for IP.
Yeah, that's interesting. And I think there's kind of a hark to what's been happening in public health. Your most recent article in that ASM journal, Pathogen Genomics in Healthcare, kind of a nice title that calls back to Greg Armstrong, Doug McCannell, and their work in pathogen genomics in public health. And it's been used for exactly those applications that you're talking about: outbreak surveillance, infectious disease monitoring, mitigation of those risks. So, from your side on the IPC world, what has been your perspective for public health adoption that's sort of caught your eye of like, oh, this is an obvious translation to what I'm doing in healthcare, and this is what we should be doing too?
Yeah, I love that article, and their figure one I cite a lot and use in my presentations because it shows that you can take things that looks like just noise in the background. So you have their figure one, because I know we're talking on the podcast, has all these dots of various bacteria, and then you apply pathogen genomics on top of it, and it just puts them together so you can clearly see the outbreak picture. Yeah, but public health has been using it for such a long time. I mean, we think of PulseNet years back using PFGE and that type of nature. They've been the pioneers that have really put it forward. So I have to give it credit to my mentor Lee Harrison, who was my dissertation doctoral advisor and still my mentor now and colleague, where he said, okay, well, public health uses pathogen genomics for PulseNet, and it works really well. I mean, public health finds foodborne outbreaks, other types of outbreaks, and they're because of PulseNet. But why don't we have a PulseNet for healthcare in the hospital specifically? And that was my mentor, Dr. Harrison's idea for his grant initially in the early 2010s of let's try to see what it could do for healthcare. Let's make a PulseNet for healthcare, and that's where it really all started for us.
That's awesome because that's where my career started on the other side of that fence. I've been in public health since the onset of the adoption of sequencing and bioinformatics. In fact, when I started at the Virginia Public Health Lab, I was the first bioinformatics scientist there
Oh,
because they
nice.
had just, yeah, they had just started sequencing data at the state level. And there was only a
Mhm.
number of us. There was literally four of us at the state level that were helping to build up this technology. And we saw its utility. I remember giving similar talks to, what I've seen you make publicly available of showing the efficacy, the strength, and almost
Mhm.
at a certain point demonstrating that, as public health scientists, we have a moral obligation at this point. We know the
Yeah.
evidence is there. We know the strength of this technology, that it helps to mitigate disease in the most powerful way. And so now, in looking at the work that you're doing, it's kind of broadening that application base of like, in a way, too, infection prevention, it's public health, right?
Right.
It's mitigating the diseases in that way. So it seems like the obvious next step application. And there was something in your article that you had in put out last year. I don't know how you're gonna feel about this. I'm gonna quote it a couple
Oh,
of
sure.
times
Of
through this.
course. Of course.
You got here written: a key issue is whether the current body of evidence is sufficient to engage and persuade healthcare lender or leaders and payers to invest human and financial resources that will allow healthcare institutions and their patients to reap the benefit. Now, today, April 2025, what is your perspective on that body of evidence? Is it sufficient to persuade those leaders and payers, investors to make this kind of investment?
Oh, that's a loaded question, Kevin. And I think it depends on who you ask, but I've had the wonderful opportunity to go to different hospitals across the U.S., conferences, hospitals, small conferences, and present our work, but also talk about other leaders in this field's work, who are some of them are co-authors on that commentary: Sharon Peacock, Patrick Harris, Lillian Abo, who recognize and have studied the value. And when I talk to these hospitals, I always say it's like it's the easiest talk I ever have to give, because everyone's like, "This is great. How do we get this? Let's do this." So I have never found conflict over the evidence of the utility, the value of it. These infection prevention, infectious disease teams have all been convinced this is what we need to be doing. So the next step is the how do we operationalize it? How do we invest in it? But I'm jumping the gun a little bit. This is another because I'm an academic. Another paper I'm working on right now is that there's an evidence standpoint, an operational standpoint, but then there's an ethical standpoint. And you alluded to this before. Is imagine if you're a patient who's looking for healthcare, and you have the choice between two hospitals. Maybe you don't have a choice too. One hospital does genomic surveillance. They're finding these outbreaks, they're stopping them, they're reporting them, they're telling the patients, they're keeping their patients safer. And imagine there's another hospital, this is the standard of care right now, who doesn't do genomic surveillance, and they're not finding these outbreaks. They're going on unchecked. It's technically not as safe as that other hospital. As a patient, what do you think their perspective is going to be ethically? Do they want transparency? Do they want an autonomy perspective of being able to choose the best care for themselves? And that's kind of another approach I think needs to be viewed is, we think, we being the co-authors on that paper and, some other people, the evidence is there. This should be happening. From an ethical perspective, should it be happening as well too? And that's up for debate, I think, as well.
I think that's important, especially there's a key perspective you're bringing this to is the academic one. And this is sometimes whenever, especially this literature gets into the application space, whenever I'm reading this, just like there's an emotional roller coaster in looking at your last article there, because you present the question, and I think as academics, we're sort of trained to hedge our statements.
Yeah,
Like, all right,
yeah.
we're saying this, but like, hey, we need more evidence. Whereas, like, it's almost like paradoxical reading through the articles. It's like, hey, we need more evidence, and then you present this slew of evidence. It's like it's
Yeah.
there, and then you go on to say, hey, here's how we can do more evidence. So I'm
Right.
wondering though, exactly to what your point is. Here, you're indicating that the key issue is the current body of evidence. I'm wondering if it's not the evidence. I'm wondering if the key issue is communication and guidance for proper implementation.
Yeah, definitely. And that's the traditional academic coming out of me of always have to be conservative. There's always room for more evidence everywhere. But I agree fully. I think you're correct. So previously to this, our approach was let's go to these hospitals, just us and other people. Let's talk to them. This works. We show you save money. There's that other review out there that also shows from a systematic review perspective, you always save money. So everyone's evidence is in the same direction. You're gonna save money. You're gonna find outbreaks. We can stop them. And we thought that was enough. To a degree, it was. Like I said, these hospitals believe us. They want to do it. Where it has fallen short, what we've seen with other people and we've talked to, is being able to convince administration to invest to adopt it. And, we were confounded because it's like, well, we're showing them they save money. Why don't they just do it? But the more we thought about it, we had to look at, okay, well, who is saving cost when you implement this? And what we're doing when we're doing genomic surveillance is we're preventing infections, and the money we're saving is by not paying for the treatment for those infections. So who pays for the treatment, specifically here in the US, is the payers, the insurance companies. It's not the hospitals who are paying for the treatment. So, the hospital will put out $100,000 a year for a larger center to do all this sequencing, but they don't get any of the money back. It's the insurance providers that gets that money back. So we said, we actually probably have to switch our mindset of how do we operationalize this? Who do we need to talk to? Who do we need to convince? And we feel like it needs to be a partnership between payers, insurance providers, and the hospitals. In the end, it's probably going to be something like NHSN HAI reporting, where a payer says, for you, hospital, if you sequence X% of your infections every month and you show that you're acting on it, we will reimburse you for all of that money that you've spent. And in the end, the infections are hopefully prevented, and the insurance provider will save money. But I mean, we're academics. What insurance company is reading paywalled, peer-reviewed journal stuff? None of them are. So I think it's the responsibility in the next steps are us in the field have to then approach the insurance providers and say, this is a new emerging technology. This is something that we need to look into together.
That's all. Okay. So there's a couple of threads I want to pull on. First is wrapping that up with the conversation of evidence. I almost just want to establish that rung in the ladder. The evidence is there, and I think in
Hmm.
terms of more evidence, it's going to be more a conversation of not does this work, does this save money, but more of a conversation of how much does it save, how
Hmm.
many lives is it saving, and maybe even more so, why aren't other hospitals doing this? That's going to
Right.
be the conversation in terms of evidence. Getting to the financial part, I've been looking at this the same way, where it looks like it becomes a cost center for the hospital that they don't reap any
Hmm.
rewards on.
Yeah.
And it's almost like they pay for something that the insurance companies or payers, whatever the system is, would reap the benefits. And I hear that argument and I see the validity into it. But I also, if I took that to the extreme, that can't always be the case. Then a hospital
Hmm.
wouldn't have an infection prevention and control system at
Right.
all. So, from the IP&C side of things, what are those incentives for a hospital to have a robust infection prevention? And can we just maybe ping on those incentives and highlight, hey, this is actually, you already invested in IP
Hmm.
for this reason. This is actually going to even more further exemplify the savings or incentives you have in the first place.
Definitely. And a lot of these things that hospitals are required to do from an IP perspective have come from mandates and regulations from CMS that if you want CMS reimbursement, you have to do XYZ. And if you want, Joint Commission approval, here are the things that you have to do. And none of that is there yet for genomics and outbreak investigation. I mean, I only know Pennsylvania here, for example, for state laws, but Pennsylvania just says, you have to report your outbreaks to the Pennsylvania Department of Health. That's it. There's nothing more specific than report outbreaks. That is actually, it's a single sentence piece of language in our state law. So I think if we want to move that forward, we have to talk about incentives and mandates, and that's where it started with HAI reporting way back when NHSN was created in the early 2000s. It was an incentive program. I mean, if you think about it, what hospital wants to, without any incentive, publicly put out, here are my HAIs, here's how many infections you get in the hospital, unless there is an incentive behind it. And that incentive helps, though. Like you said, why have an IP program? That incentive allows the hospital to make an IP program, invest in an IP program to reduce those HAIs. And I think to kick it off, that's that type of approach. We might have to see that with genomic surveillance and outbreaks.
And CMS, just for there is a bit of an international audience, so especially the conversation, the
Right. Oh
finances of this
yeah.
is so U.S. specific, right? That's the Medicare Medicaid reimbursement system
Mhm.
is what you're speaking about, and so maybe the conversation is, do we need to point efforts of getting some sort of regulatory consideration for the use of whole genome sequencing? Is that what you're conjuring up as an idea there?
Yeah, I think so. Because right now, I harp on this pretty hard in that commentary. there is absolutely zero professional guidance on the use of not only just reactive genomics, but genomic surveillance. There is zero guidance. So right now it's kind of the Wild West. I mean, a hospital can use genomics in-house. They can use a third-party company. They can use public health. They don't have to be CLIA certified. They don't have to have all these things. I mean, there's no regulation or recommendation on it whatsoever. So I think to move that forward to where we can get it to be in this incentive type program, there has to be at least a discussion of some sort of standard or recommendation or use before that can head out.
And the way I'm sort of visualizing this in my head is that there's a bar to entry. And right now it feels so high, and what we're trying to make the argument is it's worth making that jump. It's
Yeah.
worth making that jump. You save money, there's patient outcomes, there's a financial aspect, etc. But can we also speak to the concept of lowering the bar to entry? What does it actually take for a hospital system to implement this technology?
Right. Well, the funny thing is, you're taking the words right out of my mouth, Kevin. Of again, an academic, another paper that we're trying to work on is, we have shown and other people have shown, if you sequence all of these infections, here's what you can save. But is that necessary to get cost saving? Do you need to do all of them? Is there, from 0 to 100%, or is there a middle ground of 50% that you actually see cost savings, patient safety benefits? That really hasn't been established. So that evidence is still on the table, and that's something that we're trying to work out. But, you mentioned about lowering the bar. Ourselves here, we are an academic tertiary care center with a deep expertise in genomics, bioinformatics, epidemiology. What about, the suburban hospital that doesn't have any academic affiliation? What about the rural hospital and access and things like that? And I think that's where expansion into commercial opportunities comes in. Expansion into public health partnerships can come in. Because if you think about it, I mean, a lot of the tests we use in the clinical lab are commercial built tests. It's not like everyone is using these LDTs that are built in house to do their own in-house testing. That's not going to be feasible in the end. Not every hospital needs their own like giant aluminum MySeq in their lab. There's going to be room for commercial partnerships that you can send out these things to do your own sequencing. And I think that's going to lower the bar significantly to allow other hospitals to enter this space, that you don't need this in-depth genomic bioinformatic expertise to do it. You're still going to need training about how do we interpret those results and what do we do with it. But I don't think everyone needs this giant investment in genomics in-house, at least.
Oh, okay. I kind of want to go a layer deeper on that conversation. Can you speak to what is the current giant investment labs, or rather, I say labs because I'm so public health focused, but like, well, I guess hospital labs
Right.
or hospitals. What is the current giant investment that they're staring at that is kind of current state required to do it? And then let's speak to the details of, where could it be? How could
Right.
it be consolidated? How can it be, it's something like a lab test. You're getting it sequenced from a third party and you're getting a report that says green light, red light, I got an outbreak or I don't have an outbreak. So
Right.
walk me through that spectrum. What does it take right now?
Yeah, so we have a preprint out from that our lab manager Katie Waggle did on medRxiv, and she outlined our entire process, all the instruments that we have, and included a cost analysis with our FTEs, and to say like this is the investment that you'll need in order to do that. So what our process is, we have a lab tech and a lab manager that work for us here. They go down to our clinical lab, which is part of our routine clinical practice, pick up certain isolates twice a week, bring it back to our research lab, sub them out, do the library prep, and we actually send the majority of our isolates out to an industry company for sequencing. We rarely ever do in-house sequencing. We have Illumina machines in our own lab, but we have found it is more cost effective to send our isolates out to a commercial partner. So we send them out, we get quick turnaround time, and then in-house, our bioinformatician, Marissa Griffith, has built a very automated bioinformatic pipeline where the samples get automatically uploaded, gets run automatically. She does a QI check and sends it out to me. But we have her invested into this process as well. We have a lab tech invested into it. So we have, dedicated people, dedicated processes that we have built up. In the end, in her paper with the FTEs, it costs us about $90 an isolate to sequence. But that's with all of this investment that we have built in. It doesn't include the upfront costs of these machines and other things. And we also have to think, the techs and the bioinformatics people in our group, they've been doing this for a very long time. They have the expertise. So we have that built in. But what could be outsourced there? Essentially the entire process. When we look at people who are out there for industry and consulting companies, you can send out isolates to industry companies who can do all of that for you and send you back results. So I think that's something that hospitals have to weigh of, do I need to invest FTEs and machines and everything? Or is the price better to just send it out to an industry company? And that's something that every hospital is going to have their own internal decisions.
Okay, this is great because I think you're starting to break down what are those foundational components. And what I heard there is,
Hmm.
first and foremost, you have lab techs who are able to isolate, get pure cultures. That's also worth highlighting what we're speaking about here.
Right, right,
Not metagenomic, crazy mess of
right,
noise, pure whole genome sequencing,
right.
culturing, or sequencing rather. And that's the first step, which most hospitals already have, right? An ability to culture.
Yeah.
And then that second component was sequencing. And as you're mentioning, even current state, you can send that out third party.
Hmm.
Then was a couple of things that do require a lot of specialty. You talked about a bioinformatics component and then an interpretation component.
Right.
So maybe that's the area of focus of laboratories investing. But I'd also maybe note that you guys did the hard work, right? Like I'd imagine you have now protocols, you have automated workflows, and you have maybe interpretation guidelines. So
Right.
there's, I think it was Hannes from Biomir days where he used this phrase that I often say, and it was so apt in the public health space, but the conservation of misery, right? There's like one person already suffered, they got us through. How now do we all benefit? And I think I'm seeing something so similar here where you've got a protocol,
Yeah.
you've got a bioinformatics workflow, and then you have interpretation guidelines. So even as we're speaking about the bar to entry, even now, maybe it's not terribly high.
Yeah. And people get this misinterpretation too, and that's what I like to share, personally, be more vulnerable. I don't know how to run a command line. I don't know how to do library prep. I rely off of the experts to do that because that's what they're there for. And that's how we expedite things and automate things, is we can, not every person that does genomics has to be an expert at every part of the step. My expertise comes from the interpretation and how do we use and translate the results. I have an understanding of the bioinformatic pipelines and the limitations of those pipelines and, what makes a good quality measure. But I don't think everyone has to be an expert who's running their own command line, who's running their own pipelines in order to make this more expanded and accessible to other hospitals.
And this is something you harked on in that paper too, because we're talking about the automated bioinformatics. So basically, we're saying you can generate data. Labs can generate data, the low barrier of entry. But
Right.
data analysis, maybe there is still something to speak about, highlighted in your paper, the lack of standards. Especially coming from the public health side, a lot of our tried and tested workflows, analytical approaches do come from PulseNet, where
Hmm.
it's like salmonella isolates we've got hundreds of thousands of those sequenced over the past couple of years. We know how to serotype it. We know how to build a tree, whole genome, MLST, or SNPs, or otherwise.
Hmm.
Once we get into HAIs, it's not 4 or 5 different enteric taxons we're looking at. We're looking at a whole slew, a huge spectrum of biological diversity.
Right.
You're looking at mobile genetic elements, where the phylogenetic approach you take will, you'll have a perturbation in your
Right.
phylogenetic tree
Right.
by sample inclusion.
Right.
So can you speak to that conversation of methodological standards and interpretation?
Yeah, I've had some great conversations with some of the folks on that commentary there that gave some good input. And originally I thought, there has to be a agreed upon method that we all use. but that's not going to be practical in the end. Bioinformaticians are very strong-headed people, rightfully, and everyone's like doing their own pipeline with their own tools and everything of that nature. So I think the conversation needs to shift to, we might all have different pipelines, but in the end, what is the end result we're trying to interpret? Who are the patients in an outbreak? To the infection preventionist in the hospital, what they want to know is my patient in the outbreak or are they not? They, I'm not saying everything else is not important. The phylogenetic tree is really interesting. The SNP distance, the pairwise matrices are interesting. The gene presence absence is very interesting and important and good for research and to better refine our methods. But to the infection preventionist who needs to make an intervention, it's a binary outcome. Is my patient in the outbreak or are they not? So I think when we talk about reporting and methods and things of that nature, what will really matter to the translational aspect in the end from a healthcare perspective in the hospital is, can these different methods, can my pipeline and your pipeline come up with the same results saying these 10 patients are all in the outbreak and everyone else is not in the outbreak? I think that's what's going to matter most importantly in the end for the translational use.
And now even my academic training is spurring up because that's what's hard to distill down
Hmm.
because we are trained in hedging our conclusions of like, okay, here's the phylogenetic tree, here's
Yeah,
the caveats that I got to give. It's hard to just distill that down into act, don't act.
right. And I think we can appropriately hedge that. I've given this in some talks. I've gone through a fake infection prevention report that we give to our hospital, and we do go into details. We give a line list of who's in the outbreak, but we provide those bioinformatic details that everyone's interested in. But in the end, giant bold letters at the bottom, as always, genomic information should always be interpreted with epidemiologic information. We never say, just look at the genomics. Here is an arbitrary SNP threshold that we have set. Go forth, intervene. We have always said you need to do the chart review, the shoe leather epidemiology of, does the genomic information make sense? Because a lot of the times we find some genetically related isolates, but nothing connects to patients. And in the end, you can't do anything with that. There's nothing to do. So I think hedging our bets academically, like you said, always look at it genomics with epi together.
I used to give a very similar talk when I was teaching whole genome sequencing techniques in the public health space, and I would always use the little cheeky line of whole genome sequencing is meant to support, not supplant genome or the epidemiological evidence.
Hmm.
And Joel Savinsky over here at Theogen even takes it another step further. He sees sequencing data as epidemiological data. When
Hmm.
we're looking at this, it's another key aspect to
Right.
the epidemiological perspective of the transmission of the disease. And maybe this is a good time to talk a little bit about ED's hat and how the merging of these types of data that are like sample metadata with whole genome sequencing data, a conversation we're obviously having on the public health side too, which is something that you guys are obviously implementing, with full force there.
Yeah, yeah. Metadata is always important, and that's the struggle too when we think about expansion is being able to appropriately use metadata. Because I think genomic surveillance from a public health perspective really needs to be public health driven because in the end you're going to have hospitals that will have their own genomic surveillance programs, and that's going to be great that they're finding their outbreaks within their hospitals. But we have to think about, these patients cross borders, they cross institutions, and what happens when an outbreak is spanning different hospitals. Public health are going to be the leaders that need to gap that bridge. But in order to do that, they need both access to the genomic data, so having some type of genomic data sharing platform, whether that's SRA or something else, but they also need access to the metadata and potentially the PHI. And right now, I believe, there isn't one uniform system that allows us to do that and bridge that gap. And that's going to be a big barrier to tackle, but it's a good thing to tackle because I genomics benefits individual hospitals but the more people use it, I think it's exponential benefit that we're going to see across institutions.
And you talk about nice little figures there. This is, I think, in picturing your paper, the ideal state, right? Multiple
Yeah.
hospitals getting data accessible to the public health labs who have the broader regional
hmm
perspective, and maybe even the conversation across state lines. This is the exact conversation we're having in the public health space, where a single state will have their sequencing data,
Right.
but of course, pathogens know no borders. How do they, how do they assess the relatedness and potential spread across state lines? And so
hmm
you've harked on some of those tools that we use, obviously SRA, and more specifically things like pathogen detection,
Yeah.
those databases that are meant to serve as a national or really even international repository of looking at relatedness and spread of different diseases. And it sounds like from your perspective, healthcare settings could really be depositing their data into those same repositories.
Yeah, and right now, another need for guidelines is there are no guidelines about really depositing those. I mean, there are NIH guidelines that if you publish a study with NIH money doing genomic sequencing, before you publish, you should be putting it on SRA. But other hospitals are not encouraged to publicly share their genomic data. And that is going to be a key limitation that if we can't move that forward, it's not going to be as useful. But I think too that going back to that metadata discussion, it's really important because say for example you're a public health department and you're looking at pathogen detection or anything like that, and you find like a zero SNP match between two institutions, but the public health people need to have a way to show that that's not the same patient that just moved from institution A to institution B and both sequenced it and put it up there. That there's going to be so many false alarms if they're not going to have access to that type of metadata where they can duplicate some of that information. So, these are some of the data sharing, data security type of issues that, completely, I'm not quite sure how to solve quite yet.
And that's totally fair. And I think we're really talking about, again, as you guys outlined, the ideal state. And I would say the
hmm
5, 10 year timeline, right? So it is worth kind of contextualizing where we're talking about these challenges at this super regional level. All that to say, those challenges will exist. We will have to confront those. But getting back to the now, it's still obvious that this technology will help, even if you're not getting sequencing data
Right,
from every hospital in your
right.
jurisdiction or where you're transferring patients to, even in a single hospital system, before figuring out how to get the data to the public health lab, there's obvious utility.
Right. Yeah, 100%. There's definitely utility to do. If you're doing zero, there is major benefit to even just doing reactive sequencing. And that's the sequencing we call when you think you have an outbreak. There's definitely utility to doing prospective sequencing, meaning you just start sequencing isolates even if you don't think you have an outbreak, because you're going to find things like we did and other people have. But to get to that, that 5 year point, like you mentioned, I think there has to be a discussion about financials because, ourselves and the other institutions that have published on this have been primarily grant supported to do genomic surveillance and genomic sequencing. And we are seeing, NIH funding being decreased and things of that nature. So that's only going to go get more difficult to get that type of funding to do that. And it's not necessarily sustainable too. And then public health, funding is also always a difficult conversation. So there has to be that what is a sustainable long-term finance model that can incentivize hospitals to do this. And I think that's really where that payer discussion does come in.
And it feels like I'm wondering if that is already there. We just have to uncover what those levers are here. Again, because or hospitals are making
Right,
investments in infection prevention already.
right.
Maybe it's the conversation of those penalties or like, reimbursement guidelines. But I'd imagine if you were looking at it holistically, even like, workforce dedicated to an infection, you're allocating resources to something that you otherwise would not need to allocate resources to. Um, Maybe there's legal liability if there's there a conversation of like, could
Oh,
I
yes.
sue a hospital if I got an
Oh,
infection and they should have controlled? Okay, yeah, please, that
you'll
sparks
you'll
something.
get there's two conversations you really get into that I love having. Is one is the resource allocation. We're talking about we're now going to be dedicating our IPs to responding to outbreaks that we didn't know about. We have a different perspective here at UPMC is that we showed in our prior paper where we did retrospective genomic surveillance. We didn't tell our IPs what we were doing, but we also fielded requests from them for what they
Mm.
thought were outbreaks. And in that, the 2 year time frame where we did this study, we had 15 requests of, a lot of isolates where they thought they had outbreaks. None of them were really true outbreaks, meaning they were chasing these investigations that they thought were outbreaks, and they were what we'll call misallocating time and resources to these outbreaks that were not actually outbreaks. Whereas now we are appropriately investing and allocating time, FTE resources to what we know are outbreaks and what we know is making a difference in the hospital. So we view it as just better allocation of resources, even though we know we have
Absolutely.
to now actually respond to them.
And just to quickly follow up, I was even speaking on to like practitioner time.
Hmm.
So
Hmm.
like if you have an outbreak, we need to dedicate nurses,
Yeah,
infectious
yeah,
disease, etc., on an outbreak. So to mitigate those instances, we'd save on those resources. You're speaking about on the infectious preventionists themselves. They
yeah,
can't chase red herrings. So
yeah,
this technology, and that costs money, that costs time.
right,
In this technology, we're identifying that's a red herring, that's a red herring.
right.
This is something we could do something about.
Right, exactly. And to your point too, Kevin, is there was a great study out of Australia, the CLEAN study, CLEEN, in the Lancet, one of the Lancet subjournals, where they showed, better allocation of cleaning can directly reduce HAIs and save money. So kind of we're actually combining two of things like genomic surveillance, directed cleaning. There's going to be a lot of resources that are saved in the end because we're better advancing the appropriate interventions. Um,
Please.
but yeah, so
There was another thread. Yeah.
the other thread was the legal aspect, which I've been involved in discussions with in the past, both internally, externally, and I do get emails about this a lot. Most recently, last week I got an email from a hospital, and I'm not naming anyone at all. And they said, we want to start doing something similar. We're having this legal discussion. Will this make us more liable for finding more outbreaks? This is something I'm really interested in, and typically the spoiler alert is I'm going to say no, it does not make you more liable. Typically with lawsuits in the past for healthcare associated infections, it's typically with failure to treat at a timely response. It's not necessarily finding the outbreak, and that's because to have a lawsuit that could move forward from a hospital outbreak perspective, some of the things you have to show are causation and negligence to have a successful lawsuit. Typically, for outbreaks, it's very difficult to prove causation because in the past, we're on culture based results and we could never definitively say, this medical device, an endoscope, was the cause of this patient's infection if we're using culture based results. But now, if we're using genomics and especially genomic surveillance, we're uncovering more outbreaks. It's easier. I'm not saying it's completely easy to do. It's easier to say this endoscope, which was culture positive and genetically related to this patient's infection, was the cause of this outbreak. So, causation is going to be easier to prove, but there's still not a successful lawsuit there. And again, full disclosure, I'm not a lawyer. This is not legal advice. But then you have to then go to negligence. In order to have a successful lawsuit, you have to have negligence. And what is negligence in this concept of looking at a hospital outbreak is mainly a failure to act, a failure to intervene. So if you are a hospital and you're doing everything, FDA regulation or guidelines on cleaning endoscopes, and your technicians are doing everything appropriately, you're documenting it, and there are mistakes, but you're appropriately addressing them. That's not necessarily going to make a case for negligence. What negligence would be in the end is, okay, you recognize this outbreak, but you did nothing after that. So I think as long as hospitals are finding these outbreaks, making the appropriate and timely interventions, it's not necessarily going to open them up to further lawsuits.
In fact, I'd argue the opposite there. It kind of what we spoke about earlier. At a certain point, not implementing this feels negligent.
Yes, that is 100% true. I did so, you know, the things I just said came up through conversations with lawyers I've had who have done hospital outbreak litigation. And I asked that exact question, Kevin. I said, at one point, won't not doing genomic surveillance be a legal liability? And they said yes. At one point, yes. When the field agrees that this approach should be a standard practice, not doing genomic surveillance will make you liable if an outbreak is found. Because, like you said, Kevin, imagine your hospital A who is doing genomic surveillance, you're finding endoscope contamination, you're stopping those outbreaks. But if you're a hospital who's not doing it, and you find an outbreak of 20 people from a single contaminated endoscope, at some point, a lawyer could say, if you had been doing genomic surveillance, you could have prevented all of these 18 infections. That could be making a hospital liable in the future.
That's a huge incentive. That's an alignment
Right,
of incentives there for the
right.
hospitals at that point. And again, in your you're getting back to your paper, you called on the bodies of science,
Yeah.
the different organizations. How do we set standards? So what has that conversation been like when you're speaking to the SHAEs, the APICs, the ASMs, and everybody else involved about, hey, this can't be Alex's standard.
Yeah.
This has to be a community standard. So what does that look like?
No, yeah, 100% agree. It should never be a single person or a single institution that makes it. There needs to be a lot of input from multidisciplinary experts from the entire process that have to have some type of consensus guideline. But I often think in genomics and is that, perfection is the enemy of progress here. People are so worried that we have to have a single threshold for every pathogen. We have to have a single pipeline, a single methodology. We have to have, the extremely strong evidence. And I don't think that's necessarily true. I think there should be a discussion on what should be in this type of guideline or recommendation. I don't think we need sweeping guidelines to say that by next year every single hospital needs to be doing genomic surveillance. No, we're far off from that because the infrastructure is not there to allow every hospital to do this. I think it needs to be baby step thresholds of, some society comes out and says, this is a tool in the toolbox that's available and it works well. Your hospital should work its way to implementing it at some point in the future. Because, like the infrastructure is not there to make it readily available for everyone. But that's also one of the things I briefly touch on. But I'm not an expert in, and I want to work with other people who are experts in this, is equitable access to genomics. Because as we move this out, who might have better access to genomics are the more affluent areas, whether it's within the US or even globally, is they're going to have better access to it. So in areas that are not as affluent or have access to those resources might be left behind from there, and then their patient safety in those hospitals might dwindle. So we have to think about how do we have just and equitable access to this technology as it expands and moves forward.
It's again so crazy to see how parallel these conversations have been in the public health world that I generally reside in, because it's the same conversation of infectious disease surveillance, obviously bringing benefits
Hmm.
to the resource rich countries of the world or regions of the world, but it's arguably more impactful to the resource scarce regions of the world.
Right.
And so a lot of our efforts, and even something that Joel started, the Theogen Global Health Initiative, is an organization aimed at implementing these technologies in
Hmm.
the LMIC regions across the world because of how impactful it's
Hmm.
going to be.
Hmm.
So we're seeing the evidence. That's I think if anything, I want to walk away from this conversation. The evidence is there. Getting
Right.
back to that key issue, to me, that is no longer the key issue. That is apparent. It's obvious. It's been seen in papers across the world. Ad nauseum, we can go through the literature showing not only the efficacy or the efficiency, the impact, the cost savings,
Hmm.
etc. It's more about what are those implementation guidelines and how do we have that infrastructure build towards that infrastructure where that barrier is a lot lower for healthcare settings to be able to adopt this technology.
Exactly. And I'm glad that you agree because I want more people to get on board and more people to recognize it because the only way it can move forward is that if everyone's on board together and then we can have those open discussions and get the people involved who typically haven't been involved to give input, to give guidelines on these recommendations that can be made, to get access to financials and infrastructure that can build it up. I think those are the types of conversations we need to be having next to move it forward.
Absolutely. And what's been helpful on the public health side is a bit of that academic spirit that we all took with us is the open source technology,
Hmm.
the sharing. Publications is tough.
Yeah.
It's not always at the forefront of public health laboratories. Some are a little bit more academically inclined, and that's the sort of the currency they run on. But a lot of public health labs aren't. I'd imagine a lot of hospitals outside, again, the academically associated ones, aren't necessarily publishing, outbreaks. I know you've
Hmm.
spoken about this in the past,
Hmm.
but if we can encourage people to do so, that just adds to the body of literature, adds to that critical mass. Of a certain point, it's like not should I do this, but more so the more important question is why are you not doing this?
Exactly. Yeah. And it's I always when I talk to people because I've been curbsided as I call it in the clinical world to help on outbreak investigations with individual hospitals. And at the end, I'm always like, this is something you should publish because without publishing it, it's hard to spread and tell that story. That this is something you found, this was an opportunity for improvement because there's this teaching approach that I'd like to take, and I have to give credit to Carl Bergstrom, who's an epidemiologist. He said like don't just show people examples of success. You have to show them examples of failure, and for our field, that's outbreaks. Outbreaks are examples of failure of where something went wrong, and by publishing it and showing it, it enables every other hospital, every other public health system to learn from it, to improve upon it, and only then can, patient safety get more benefit from there.
That's huge. Yeah, because again, it doesn't only highlight that infection's happening, but how did the actual infection spread? Is there a device that they had to
Hmm.
look at more closely? Is there a cleaning protocol, hygiene protocol that they had to consider that they've now implemented that again just pushes the field forward? Well,
Hmm.
Alex, this was an awesome discussion, man. I appreciate your perspective, work in the field in general, and yeah, I'll continue on, blowing through the megahorn of like adopt this technology
Exactly.
throughout, and
Yeah.
we'll see how things get through. Is there anything else you want to close on in
No,
final thoughts through this?
that's a perfect place to close on. I mean, I'll just say that it's wonderful to meet so many people in this field, bioinformaticians, lab folks, public health, academics, hospitalists, having those open conversations together where we can all talk about what works, what doesn't work is really the only way to move it forward. So I'm eternally grateful for everyone that I've been able to meet along this pathway, and really looking forward to see where this can go in the next 5, 10 years.
Solid, man. We'll be continue following your work, and hopefully this was awesome. Hopefully this is the first of many of these discussions. And next year we're talking about those conversations. All right, now every hospital sequencing. How do we get it to the public health labs? That's the next
Exactly.
challenge.